Hi everybody, this is my part of the integrase inhibitor and or TAF leading to weight gain debate. I'm taking the pro standpoint. Now, when I was given the pro standpoint, I thought, well, this is easy. Eye roll. I mean, it's obvious that this is the correct standpoint to take, or OVS as they say, which you'll be pleased to hear is now in the Oxford English Dictionary. Now, Jürgen, of course, is taking the con standpoint, and knowing Jürgen, who is highly entertaining, he'll be taking a quite comedic view. He'll be sharing anecdotes and maybe some old pictures of him and his colleagues in the pre-heart era before I was even born. But I don't need humor to win this debate. I'm going to stick to scientific fact. Fact one, people with HIV are getting heavier. Now, many argue this is true, but it simply means that people with HIV are catching up with the general population. However, that's not necessarily the case. Now, this is data presented this year from the Kaiser Permanente cohort, looking at people with HIV starting ART and comparing them to HIV negative controls. And you can see in the graph that over 12 years on ART, people with HIV are gaining more weight than HIV negative people, but they're simply catching up. And after 12 years, their BMI is approaching that of the general population. However, that masks the fact that if you look at different weights at baseline, a different story emerges. Now, on the far left, for people who are underweight or have normal weight at baseline, you can see greater weight gain in people with HIV, and they actually end up slightly heavier. Now, that could be a good thing if they were underweight to start with. However, we do know that weight gain, even within a normal BMI range, is associated with a higher risk of diabetes, for example. On the far right, for the obese groups, there's really little difference. But for me, most importantly, the people who are overweight at baseline, if they have HIV, they're gaining about twice as much weight over the 12 years than people without. And despite starting at the same point, they're ending up 1 BMI point heavier. Fact two, some drugs are associated with more weight gain than others. Now here, I'm not going to go through all of the evidence from case series and cohorts and RCTs that some drugs are associated with more weight gain than others, because you know that data already. The one I will highlight to illustrate the point is this Paul Sachs analysis of 8 first-line Gilead RCTs over 96 weeks with more than 5,500 participants. And we're seeing a clear difference between the second-generation integrases and elvitegravir on the left, and a clear difference between TAF and other NRTI backbone agents on the right. Many other studies support these results. However, perhaps more importantly is fact three, and that's that there is a clear temporal relationship between antiretrovirals and weight gain. Now, a number of cohorts show this, and cohorts are important, of course, because you can look at weight trajectory prior to the initiation or switch to a particular agent, whereas cohorts, you don't have that ability. This is the OPERA cohort presented earlier this year, showing that switching TDF to TAF while maintaining all other regimen components associated with a clear acceleration in weight gain. Prior to switch, the annualized weight gain in this population was 0.42 kilos. For the 9 months after weight gain, it was 2.64 kilos per year equivalent, and after that it plateaus to 0.3, but a clear temporal relationship. Fact four, there is biological plausibility for antiretrovirals being associated with weight gain. Now, one of the most discussed is the POMC and MC4R system. This is the most potent physiological control mechanism of food intake and metabolic energy balance in mammals. And the diagram on the left is from a recent Nature paper hypothesizing how integrases could impact on this really important mechanism to lead to weight gain. On the right is data looking at how integrases do inhibit this receptor. Now, albeit not at usual physiological concentrations, but we must consider that this is very early research, and it's not allowing for considerations like receptor occupancy time, which we know is much longer, certainly for integrase binding for second generation drugs. And it's also not allowing for the concentrations that different drugs may achieve in different tissue types. So for me, this is a really important mechanism worthy of further exploration. The other important mechanism is the gut microbiome. Now, the gut microbiome is already well established as one of the mechanisms by which antipsychotics are associated with weight gain. Risperidone, for example, such that if you take risperidone-treated mice and transplant their feces, therefore their microbiome, into risperidone-unexposed mice, those new mice get fatter. And actually, that's been shown in humans as well. And the gut microbiome really is one of the crucial elements controlling weight. What about antiretroviral? So there's already some evidence that integrases are associated with the least harm to good bacteria, which are associated with nutrient absorption, whereas PIs can cause harm. So there are already mechanisms related to gut microbiome that could explain differences between drug classes. And there are innumerable other mechanisms. This is a list taken from a paper on antipsychotic-induced weight gain, and many of these have not even yet been analysed in the context of antiretroviral. So don't confuse the absence of association through lack of study with a true absence of association, and these all need to be explored. Indeed, the authors of this paper concluded that genetic polymorphisms may explain individual variation for antipsychotic-induced weight gain, and we need to explore this better for HIV, where we've seen a clear association between ethnicity and gender and weight gain, for example. And final fact 5, weight gain is harmful, and it's in nobody's interest to ignore it or to deny associations with particular drugs. You'll be familiar with all of these, but as a brief reminder, being overweight or obese is associated with a higher risk of asthma and sleep apnea, with coronary artery disease and other undesirable cardiovascular outcomes, with depression, impaired quality of life, and cognitive impairment. Importantly, of course, diabetes, but also musculoskeletal and joint problems. A number of cancers have a clear association with overweight and obesity. And finally, an increased risk of death. So let's end on why is this particularly important for people with HIV? Well, regardless of the reasons, people with HIV have a higher risk of age-related comorbidity, and they also experience the consequences of polypharmacy through our use of lifelong drugs associated with drug-drug interactions. And as HIV transmission and new cases decline, people with HIV will be older than the general population. So let's finish on ethics and the ethics of using drugs associated with weight gain. Beneficence to do good. Are they doing good over and above drugs less associated with weight gain? I'd argue not. Non-maleficence to do no harm. Are we doing no harm by using these drugs? I'd argue not, that there is a risk we are causing unnecessary harm to our patients. Justice. Do we need to use these drugs over and above other choices on a population level? Well, in some cases, yes. And I think the use of dolutegravir in place of efavirenz for global antiretroviral schemes is, of course, a good thing. But could we argue that, for example, we need to use TAF for most people on a population level? I'd argue definitely not. And finally, autonomy, what is best for the individual, which will, of course, vary case to case. But I think it's hard to think of an example where other alternatives exist that using the combinations most associated with weight gain is necessarily the best thing for that individual person. So I'll finish on this. In my humble opinion, it is not ethical to choose art associated with weight gain where reasonable alternatives exist. There closes my argument, and thank you very much for your kind attention.